I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Dr. Sammy, Sinno, Amanda Silva, and Raj Sawh-Martinez. Enjoy.
Hello, everyone, and welcome to the March PRS Journal Club. This is Raj Sawh-Martinez, and I'm joined, as usual, by my fellow co-resident ambassadors, Sammy, Sinno, and Amanda Silva from University of Chicago, and Sammy from NYU. This month, we have the privilege of being joined by Dr. David Song as our current ASPS president. Dr. Song, thanks so much for taking the time out of your busy schedule and time with your family to join us.
Oh, this is my pleasure, guys.
So in this section, we'll be discussing a study out of the MD Anderson Cancer Center entitled Deciphering the Sensitivity and Specificity of the Implantable Doppler in Free Flap Monitoring. And it's authored by Dr. Chang and his colleagues out of Houston. Before we get into the data, I just wanted to mention that there are two associated articles paired with this selection and all the other journal clubs from this month, which will be available on the PRS website, and they each include a CME, and for this topic, it'll be one on microvascular surgery, all of which are available for free as part of this month's journal club. So getting into the study by Dr. Chang et al., they sought to provide a comprehensive evaluation of the sensitivity and specificity of implantable Doppler use in detecting flap failure, regardless of the region being reconstructed. The authors performed a retrospective review of all free flaps performed at the MD Anderson Cancer Center over a 13-year period between 2000 and 2012. They report the use of a Cook-Schwarz Doppler in 439 patients, finding an overall sensitivity of 77.8% and a specificity of 88.4% for the ability to detect free flap failure. The manuscript is full of key details that are really important to interpreting these results. We'll go through some of them. The study included free flaps for breast, head and neck, and extremity reconstruction, with the majority of their flaps falling in the head and neck group. They describe placing the Doppler, mostly on the artery in the majority of their cases, and for 71 of the patients, they placed it actually on both the artery and the vein. From these numbers, they report an increased specificity and sensitivity with the arterial monitoring compared to the venous monitoring. They note that the specificity increases to up to 94.2%, and the sensitivity was increased to 77.8% when the Doppler was placed, compared to when the Doppler was placed on the vein. Interestingly, they also noted a higher specificity and sensitivity for flaps that were clinically monitored. This accounted for 63% of their overall cases that were studied. In those patients that had a clinically available monitoring segment, the sensitivity rose to 80% from 66%, and the specificity rose to 90% from 84%. Overall, the authors reported a 5.2% rate of total flap loss in this 13-year span, and noted that for buried flaps, there was a high sensitivity and specificity. However, there were positive findings in less than 60% of those that got taken back in that specific group. The authors also found that obesity and chemotherapy increased the likelihood that a take-back would result in a positive finding, but that the presence of a skin paddle or a monitoring segment actually had the greatest impact in having a true positive finding. In their conclusion, the authors advocate for placing the Doppler on the artery, given the increased specificity, and note that clinical exam remains the gold standard for flap monitoring. This study is the first to really compare the use of an implant Doppler on multiple free flap reconstruction sites and in such a large series. I think these findings that really refute some of the main findings in the use of the Doppler, most notably for being placed on the vein. Here they're advocating for the artery instead. I was curious to see, Dr. Song, you're one of the world's experts on free flaps. What are your thoughts? Do you use the Doppler frequently? Do you agree with putting it on the artery?
This is a really interesting article looking at a vast array of varied free flaps from multiple different surgeons at a single institution. The question that you asked, Raj, is really interesting because I personally don't use the implantable Doppler at all. I have a colleague that uses it routinely, but I personally don't. What you said a little earlier about the fact that in this article, when there's a skin paddle, the specificity and sensitivity went up dramatically, and yet they prefer to put the implantable Doppler on the artery, are two sort of opposing strategies, right? So when you're looking at a skin paddle, the first immediate sign of a flap failure or flap compromise is congestion and then going on to being turbid, and the turgor of the flap and then the edema of the flap increases. So it's usually when flaps go down, by and large, they're dramatically more venous problems than arterial problems. So by the time the artery goes down, the flap is already swollen and it's congested, and I think the salvage rate for a congested, swollen flap is going to be less. An example to illustrate that, when you have a blood pressure cuff on and or a tourniquet on, you're going to get, unless you exsanguinate the limb, you're going to get more congestion than you do before the artery goes out, just like a compartment syndrome. It'll be swollen, it'll be congested, and then the last thing to go is the artery. So when Dr. Chang in this article and Dr. Yu and the authors advocate for placing the implantable Doppler on the artery, I think, unfortunately, when it goes down on the artery, it's almost too late. And so they're definitely finding probably a higher specificity, but the sensitivity and the flap salvage rate may be suspect. And so that's why you're seeing exactly in their data, when you have a skin paddle and you use the Cook Doppler, you're having a better outcome. And clearly it's because the skin paddle is showing you the venous side of things, and the implantable Doppler arterial side of things. And when the artery finally goes down, it's almost always too late. And so those are my thoughts on monitoring free flaps. And we personally, at University of Chicago, we prefer the near-infrared spectroscopy because that's extremely sensitive and highly specific, and it gives us virtually real-time readings on the flap. And there have been so many times where we've taken the flap back just on the number alone, and by the time we're about to open the flap, the flap is starting to turn, and maybe Amanda could comment on that because she's got some personal experiences with the way we monitor flaps. But it gives us a early warning detection. It's kind of like a early missile detection system. By the time a system goes off, the missile's already going to hit somewhere. We're able to, I think, be able to see before the missile. I mean, right as the missile is launched, that hey, this is coming near us. We better do something about it. And by that time, we're actually able to do something about it. So
describe it a little bit more. Can you describe the infrared system a little bit more? Because we actually
sure.
That high.
Yeah, it's near infrared spectroscopy. It's akin to pulse oximetry. It shows us the hemoglobin molecules, and when we start to see a dramatic dip, or even a relative dip of more than 20 percentage points, it's typically a sign that there's flap compromise. And this happens way before clinical signs and or Cook Doppler signals start to see anything. And so, oxygenation of the flap is clearly something that is an early warning sign of flap compromise. Many times it's just spasm. Many times it's gravity and causing spasm of the vein and or artery. And when we put the patients back in a resting position, they usually go up. And if it doesn't, it's usually a sign that something's happening, and we'll take the patient back purely based on persistent decline in saturation. So the advantages, and I don't want to mention any companies, but the advantage is the company that we use, we're able to get real-time alerts on our iPhone. And so we're able to see flaps, really sort of go through the, throes of acclimation after surgery. And we're able to see, I can actually tell when a patient gets up to go to the bathroom post-op day 1 or 2. It's really striking.
And a reasonable amount of false positives or none at all?
We have had very few false positives. And, I would love Amanda to comment because
I can only recollect one false positive I've had as a resident. The rest of them were true problems. But there's a little bit of angst from the resident side because the resident has their cell phone and asking you what's going on. I think it just makes everyone pay more attention to the flap as well. But I echo what Dr. Chang says. I think that for me, going out as a junior microsurgeon, I would want it. So.
Yeah, I mean, I'm a senior microsurgeon, and I can't. I love it because it really does allow me an extra added layer of comfort. And perhaps it is the Hawthorne effect, right? Because it is so sensitive that everyone's more tuned to these flaps. So back to the article, when you have it on the artery and the artery goes down, well, my goodness, 90+% of flaps go down because of the vein. And by the time the artery goes down, the vein's been down for 2+ hours. And so you go back in there, and if you've ever taken a flap back, you'll notice that when you take the flap back, let's say in a deep flap, the signal may be still there, and the flap is purple. And by the time the signal goes out, my gosh, that flap is usually going in the bucket. And so to me, the strategy, while they found it retrospectively to be beneficial, I just think sometimes they may be missing the point here and an opportunity, because arterial compromise is usually the last thing to go. There are certain situations that do
you think that it's more that the Cook Doppler is just more reliable for the artery than the vein? Because it seems like with the vein, it's just not very reliable.
Could be. Yeah, the other thing that I want to comment on, the Cook Doppler, any implantable Doppler in the head and neck region has a lot of noise because it's so vascular. You have a ton of veins and arteries in and around your anastomoses. And so, we've been fooled many times when we've done a buried flap where, you hear a whoosh, 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 and it's not necessarily the vein that you put the coupler around, but it's, the internal jugular vein. And the vein that we really want is down. And so it almost gives you a false sense of security. So those are the things that I think clearly there's a learning curve to all this. If, in my opinion, if you're going to use it for a buried flap, I personally think that you better put it around the vein and, proximal to the anastomosis, and so that that that's the first point of compromise, and away from areas that have other veins or arteries that can give you Doppler noise.
Yeah, I think so. We have actually experience with similarly, like you guys are mentioning. One of our microsurgeons uses it routinely and has for years, and he actually has always been putting it on the artery, and even despite studies that always had the vein. So we always sort of question him, and part of that, some of that nuance that didn't make it into the discussion in this manuscript, but I think may play a role. There's an opinion that sometimes for monitoring on the floor for the nurses, it's easier to understand and hear the arterial signal versus a venous signal. The venous signal could sometimes in a big vein be just sort of a longitudinal whoosh without sort of that biphasic signal. And sometimes there's even changes in the quality of the arterial signal can mean, that something may be wrong with the vein. So if there's a water hammer signal on an arterial Doppler, we'll often be attuned to, is there a problem with the vein? Some of the challenges have been when we do completely buried deep flaps with an arterial Doppler, and then it becomes water hammer, then, well, is this positional, like Dr. Sawh was mentioning, the patient get up and go to the bathroom and now there's a change, or is this really, flap really swollen? Do we need to go explore it? So I think, the knowing how to use the arterial Doppler, I think may be one of the challenges, or maybe one of the things that leads to a higher specificity in the study, because they've become more used to it if they've been putting it on the artery for so long. But I think probably in institutions where they've been putting it on the vein continuously, maybe those nurses and that staff is much better at also detecting it, not having issues like we've had sometimes when, new staff is now listening to a Doppler on the vein and just maybe not used to it as well.
Yeah, and that's absolutely correct. I think back at the paper, and the best results is when they have a monitoring segment and on the artery, right? So, that gives you a window on the vein and a window on the artery. And so for buried deep flaps, and we do a few, so my residents go crazy when I completely bury it, and Amanda will attest to that. So we always leave a little, they try to convince me to leave a little paddle, because it does give us a window where we could put the near-infrared spectroscopy monitor on and or look at it clinically. And you can always excise it in clinic under local. And that seems to be a better pathway. In head and neck, we try to do a monitoring segment for a lot of things, and that gives us a insight into and a window into the venous outflow as well. But once again, you've trained a set of nurses to really listen to the arterial side of things. If they call you in time, so let's walk through this. So the artery finally goes down. They call the resident, hey, the artery's down on this flap. It's a buried flap. By the time the nurses has noticed that means the artery's down and the vein's been probably down for 2-3 hours. And so now you're calling the OR, and by the time you're in the room, the vein's been down for probably 4 hours or so. now you're looking at a salvage situation. If you're going to salvage it, where you've got to do all kinds of heroic things like thrombolytics and Fogarty catheters and so forth. So, in my opinion, and this is just my opinion, but I think it's shared by a lot of experienced microsurgeons, the venous problems are the worst. Because if an artery goes on, the veins open, well, you got a lot more time. It's not warm ischemia and congestion. It's just, ischemia. So, you've got a lot more latitude to do something with it. But boy, do I want to know when a flap goes down. I want to know when the vein goes down, like before it goes down.
Right. When we use these, we only have really one surgeon that uses the Cook, and it's for head and neck flaps, and we put it on the vein, and that's it. So it does occasionally, if the patient, post-op day 3 or 2 is agitated and moved, and there was one incident where we just lost it, and it was a tough decision whether to go back or not, but the surgeon ended up not, and the patient did fine. But I think the one other thing is a false positive does have a lot of repercussions, not only just angst for the surgeon, but also operating room time and anesthesia and patient risk. So I think with all these methods, it sounds like we're saying that no matter what method you use, obviously something reliable, and there's really nothing that beats sort of prompt clinical diagnosis and hovering over those flaps for those first couple of days. Do you have a microsurgical ICU, or is Chang the only place in the world that has a microsurgery ICU that we know of?
Well, I've been to Changgang, and it's a beautiful one, and they have extremely well-trained nurses. They don't necessarily use any technology. I think they just use a handheld Doppler and really more clinical exam. We at the University of Chicago, most of our patients, unless they have airway issues, go to the floor. And so we're able to, once again, see real time what their flaps are doing. In fact, I'm actually looking at a flap right now on my iPhone. It allows us to see things before even the nurses can see things. I mean, I remember I was in Dubai, and I did an SIA flap, and I saw it going down, and I just texted one of my residents a few years back, hey, what's going on with Miss So-and-so? Oh, nothing. She's fine. I saw her just a few minutes ago. Well, I'm seeing this, and sure enough, she had been standing up to go to the restroom. We got her back down, and the flap came back. But I'm able to see it wherever there's Wi-Fi, and so you're able to call the nurse. It does, and Amanda's absolutely right. It does cause a lot of angst and anxiety for the resident because they're getting texts in the middle of the night. Hey, what's going on with Miss Jones in room 9024? Why is it going down? But you know what? I will say that. Over the course of the last 20 years of being at University of Chicago, with near-infrared spectroscopy, we've had more take-backs, yes, I would say, but take-backs and the salvage rates are very high because we're literally catching these things before it's too late. And you have to have a low index of suspicion. So false positive, boy, I'll take those any day. I mean, if you take it back to the operating room and you do a washout, I'll take those any day. Because the cost of care goes up when you lose a flap dramatically.
Of course.
So
how long,
for the young microsurgeon.
You've been using it for how many years? How many years have you been using it for?
Oh, this goes back to 2003. I think I was one of the first to do a prospective randomized trial looking at bioptics in the ICU and out of the ICU. And so so we've been using it for quite some time. And only recently has it sort of been iPhone capable, and now we're going to get text alarms, so that's going to end up even more.
Good thing Amanda's graduating soon.
Yeah. Now you need to give your phone to the intern. That's the next step.
That's right.
Well, that's great.
And actually, one of our other associated articles for this month's Journal Club here also talks about using smartphone with another application for microsurgery monitoring. So I think that's certainly the wave of the future. And I think there's been a great discussion, lots of controversy, and lots of subtle points for the young and experienced microsurgeons. So, Dr. Song, thank you so much for an excellent discussion. And I think we'll carry this on online. Thank you so much.
Yeah. Sammy, Raj, and Amanda, this was a pleasure, and I really applaud you all for doing this. And I think that this is a great thing that we're doing for PRS and for ASPS and our specialty. So thank you for getting me involved.
Thank you.
Thank you.